Good morning and welcome to today's webinar, Quality Assurance Requirements Phase B. I am Paige D'Angelo, Project Coordinator at CIBHS. Our trainer this morning is Rod Libbey, and also with us is Yvonne Frazier, Project Manager for the DMC-ODS Waiver Training Project. Please note that all attendees are in listen-only mode. We encourage you to submit your questions and comments at any time during the presentation by typing your questions in the questions box on your control panel. You should have received by email a copy of today's slides and additional handouts. The handouts and slides are also available to download in the handout section of GoToWebinar. There will be a brief survey at the end of this session, and we thank you in advance for taking a few moments to share your feedback. We read your comments carefully and use them to inform future training. And now I'd like to introduce Mr. Rod Libbey. Rod's career in the behavioral health field began 40 years ago in a small nonprofit in Central California. He went on to spend 17 years with Bank of America developing and implementing the company's first employee assistance program and later managing employee relations nationwide. More recently, he was interim executive director of the Mental Health Association of San Francisco and was CEO of Walden House. He has a bachelor's and master's degrees from the University of Oregon. Welcome, Rod.
Thank you, and good morning. You heard from that brief bio that I've been in this field for a long time, longer than I like to think about sometimes. And, you know, one of the things that I want to talk about sort of right from the beginning here and give you a little bit of sort of high-level background on the DMC-ODS, which I'll refer to in the training this morning as the ODS, is that in the past, prior to the ODS, substance use disorder programs didn't have a whole lot to be concerned about in terms of quality standards and standards around access to treatment and that sort of thing. You know, when our programs were reviewed in the past, they were reviewed primarily for licensing kinds of issues and safety issues and staffing and that sort of thing. But there wasn't a lot that was connected to the quality of care that was going on in the programs or access to the programs. So along comes the DMC-ODS, and along with it is a real concern with quality of care and access to care, and it brings a lot more sort of work and detail that we need to be concerned about, which is in the long run is a really good thing. I mean, it's good that we are concerned about these things, but it's a little bit scary for a lot of people who've been in the substance use disorder field where that wasn't really a concern. It wasn't something we needed to spend a lot of time on and save a lot of data and have databases and be able to analyze data and that sort of thing around quality, which we now have to. But under the ODS, there were some promises made when the feds implemented the ODS. They said that, you know, we're going to provide Medi-Cal funding for a broad continuum of care so that all stages of treatment will be covered by Medi-Cal. Things that weren't covered in the past, residential care, case management, recovery services, these kinds of things will now be covered. However, we want to be sure that people are in the right level of care, the right medically necessary level of care. And we want to be sure that people have access to care and that the programs will be of high quality and outcomes will improve. So it's sort of like the feds are saying is we're going to spend more money, we're going to do something that's much better in terms of coverage. It's a much broader program, but we're going to be concerned about the quality of care and access of care. People are going to be entitled to partake of these programs, but we want to be sure that they can access them and that the programs are good. They added one other sort of promise to all of this, which we're not going to talk a lot about today, and that is that these programs will be of, they won't cost anymore. The idea was that if people are in the right level of care, the right medically necessary level of care, that they won't always be at an expensive level of care, and that's going to control the cost somewhat. And an example might be that if you have somebody who is approved for 60 days of residential care, if they're doing well in residential care, they should be ASAM'd or assessed and probably placed in a less intense level of care, which is also a less expensive level of care. So if you sort of follow that through, their idea is that even though there's more treatment for more people, that it's not going to cost any more than that. So also at a kind of high level, I want to talk a little bit about how this whole quality thing works. When counties wanted to opt into the ODS, they had to do an application or a proposal to the state that basically followed a template that is on the handout that you have. You have a handout that goes with this training that says something like Quality Assurance B and Drug Medical Organized Delivery Systems. In that is a thing called Attachment Z, which is the template that counties used in writing their proposals to the state. And in Attachment Z, there's a listing of all of the quality issues that have to be looked at in terms of treatment. And so that's where it sort of begins, because when counties opted in with the state, they basically said, we will do these things. We are going to follow all of these quality standards. So in effect, a lot of the stuff that we're going to be talking about today, a lot of the quality standards are things that counties have already promised the state that they will do those things, and they're not really subject to change or anything like that. They're things that we have said that we're going to do. Also within that proposal to the state, counties have said that we will have a quality improvement committee, quality improvement plan, a utilization plan, and those kinds of things. So those are also included already in the contract that counties have with the state. And why is this important to program management and staff? It's important because it will show that you need to have evidence that these quality and access issues are being taken care of. You've already basically said in your proposal that you're going to do these things. And so we need to see how are you as programs, as counties, going to be able to show that your quality and access issues are being taken care of. Quality issues, by the way, are reviewed primarily by the EQRO, External Quality Review Organization, and those reviews will happen basically once a year. So I want to make one other statement, and then we'll get into the slides on the training, and that is that everybody understands that all of the quality and access issues are new. They're new to the field. They're new to the substance use disorder field. And there's a lot to it. It changes the way people do assessments of clients coming into treatment. It changes the sort of speed and fluidity with which you have to bring people into treatment, the way people can access treatment. And it's a lot of stuff. It's a lot of new stuff that needs to be done, and everybody understands that. And to that end, the EQRO folks, the folks who are going to be reviewing quality and access issues, have said for the first year, certainly, and probably the first couple of years, they intend to work as much as coaches, as reviewers. That is, they know that it's a lot of new stuff, that there will be that certain counties and programs may have some problems meeting some of the standards, and their role will be in helping folks figure out how to meet the standards, rather than coming down on them real hard for not having everything in place in the first year. So try to keep that in mind as we go through this. If it seems at some point like this is an awful lot of new stuff that we've got to do, that everybody understands that it's going to be a learning process, and you'll get some help and understanding along those lines. Okay, so to begin with, phase B of the training that we're doing today is part of a three-part, three-phase training. If you didn't go through the phase A, don't worry about that. We're going to be covering a lot of that today as well, so it isn't like you need to have that in order to follow what's going on today. And then phase C has just been actually completed and will be implemented in about a month. There will be a training, the first phase C training, and I would highly recommend that people sign up for that, those trainings when those are available as well. Each of the phases get into a little bit more detail in terms of what the expectations are around quality issue. Okay, next slide. The learning objectives today, just very briefly running through those. We will talk about the context or the purpose of a quality improvement committee, something that every county will have. We'll clarify the purposes of those. Also, what the structure of the committee will be and the different ways that a committee might be put together within a county. And then we'll talk about the content. What is it that the Quality Improvement Committee needs to look at? What are the 5 issues, 5 areas that the QIC is required to address, and how those relate to its primary purpose? We will talk about at least 5 databases that counties and programs will need to have in order to monitor what's going on in terms of keeping up with the quality items. We will identify at least 3 differences between DMC-ODS requirements and specialty mental health requirements. We will not spend a lot of time on that, but I'll direct you to the information that you need. It basically says that things like the symptoms required to find the correct level of care for folks is considerably different in substance use disorder assessments than it is in mental health. But it's not something we're going to spend a lot of time on today, but we'll direct you to that. And finally, we'll identify issues for phase C training sessions. So if there are things that we talk about today, but you'd like more detail, or there's things that we don't talk about at all today that you want to have information on, keep track of those, and you can put those in your evaluation so that we can add those to the phase C training as well. Slide. So the Quality Improvement Committee in its organizational context, and I always like to use the word purpose instead of context. So what is the organizational purpose of the Quality Improvement Committee? What's behind this is the word entitlement, and you'll see the word entitlement in the next few slides probably a couple of times. What the ODS does is it establishes certain entitlements, and they want you to think about the fact that Medi-Cal beneficiaries are entitled to services that are medically necessary, accessible, and meet quality standards. And I guess what's really behind that entitlement is that these are not just like sort of in the prior to ODS, services might have been available if people could find those services and get into those services, but there was no idea that folks were entitled to them. Under Medi-Cal, if somebody is Medi-Cal eligible, and consequently Medi-Cal enrolled, but if they're Medi-Cal eligible, then they have a right to the services that they need, substance use disorder services. So it's a little bit of a different world that way. So we have The next slide is a poll, and it has to do with the ODS obligation. There are 4 poll questions, by the way, in this training, and you're not going to be judged on whether you get these questions right or not. These are really sort of poll questions that we want you to respond to, but they're really to get people to focus on the areas that we're talking about more than they are a test of your knowledge. So if you would, the first question is, under the ODS, treatment programs are responsible to meet the treatment needs of, is it all Medi-Cal beneficiaries or only those Medi-Cal beneficiaries who are in treatment? I'll give you a second to respond to that. Yes? What? Do you know what the answers
So most people said.
Okay, good. Sorry, that took a little bit longer. I was trying to find out what your answers were. So 78% said it's for all Medi-Cal beneficiaries, 27% for those Medi-Cal beneficiaries who are in treatment. So again, the sort of correct answer, or the more correct answer, was number 1, that we're really looking at the fact that, and this goes back to that entitlements thing, that treatment programs are responsible to meet the needs of all Medi-Cal beneficiaries, right? So it's kind of a new world, if you want to think about it that way. In the past, in the treatment world, in the substance use disorder treatment world, we worried about people we had in treatment. We worried about people who were on our caseload. If we were asked for information, for data on treatment, it was only for those people who made it onto the caseload. Now our concern has to be with everybody who is Medi-Cal eligible. Anybody who might want our services, anybody who comes knocking on the door, we have an obligation to see that they are at least assessed for treatment. Okay? All right, next one back. That one there, that's fine. Okay, good. So, a quality improvement program, as I said before, all of the counties have a quality improvement program if they've opted into the ODS, and if their proposal and contract was accepted by the state, then there is a quality improvement program in that contract. And its primary function is to assist ODS administration in meeting its obligations to beneficiaries for access to services and quality of care. All right. And again, previously we only had to worry about our SUD caseload, the people we were treating, but now it's all Medi-Cal beneficiaries who may ask for care are concerned. These are the 5 mandated QIC functions. These are the things that, the 5 items that the Quality Improvement Committee, and we're going to talk a little bit about what that committee is and what it looks like. But these are the areas, the 5 areas that they need to be concerned about. Quality Improvement Committees will recommend policy decisions. So when you're looking at how you're going to provide services to meet all of the standards and regulations under the ODS, you may want to put that in policy form so that everybody is following the same path to get those things done. The Quality Improvement Committees will also review and evaluate the results of QI activities. So you're constantly, the counties are also, prior to the EQRO reviews, are doing reviews of what the results are. If there's a need, the Quality Improvement Committee will be the first local area that will see that maybe things are not going as well as they could. Things could be done in a more efficient or effective way, and they would institute then actions to make sure that things are working better, and then follow up on that process to make sure that whatever the policies say and whatever the instituted actions are being done. And then finally, the Quality Improvement Committees need to document minutes regarding decisions and actions taken. And this is the first sort of area that pops up in this training that talks about documentation. And this also, I think, points to something that's a little bit different than the way things have been done in the past. The reason that all of the things that show that a county and programs are taking care of the quality items that need to be taken care of are done. Those have to be documented as you go so that when there is a review, you'll be able to show evidence of the fact that you're actually doing those things, right? I know when I was working in the substance use disorder world, I probably went to, I don't know, 8 or 10 meetings a week in which, community meetings and in-program meetings and county meetings where we talked about how we were going to do things differently or do things better to improve on things. And people were given different assignments, but maybe, I don't know, 1 or 2 out of 10 meetings actually had documented minutes that you could use to follow up to make sure that things were being done and things were being taken care of. When EQRO review time comes and they come in to see what it is that you're doing in the areas of access and quality, having documented committee minutes shows evidence at least that you're looking at the things, the 5 mandated functions that you should be looking at, and that you are maybe proposing some things to make the quality and access issues work a little bit better. So documentation, data, those kinds of things are a little bit new in terms of their importance, and you'll see that throughout. Next slide. So this one says, while meeting its primary purpose, a county's QI program can do some other things. If you have a quality improvement committee, you can just do those 5 functions. You can just do the sort of minimum kinds of things that you need to do within that committee, or you can do things like improve organizational development, make your programs more efficient, productive, improve interagency relations, you can promote the quality of clinical practices, improve client outcomes, promote, maintain credibility in the community. What they're really saying here is that what would be probably a good idea is to look at the Quality Improvement Committee and quality improvement work as being something more than just dotting the I's and crossing the T's. As we get further into this, we'll talk a little bit about what are the real quality standards, what are the sort of regulations, if you will, the things that you have to do. You can use your Quality Improvement Committee, your quality effort, to just get those things done, Or you can take it a little bit further. You've got this great committee of people who are concerned about quality, and they represent different areas of behavioral health and health services and the community. Then why not, pick up some other items, set some other goals around quality that would make the effort a little bit broader and a little bit better. Next slide. And this sort of talks in a little bit more detail, this slide about pro forma implementation. Pro forma implementation means that you just do worry about dotting every I and crossing every T, that you're meeting the letter of the law rather than the spirit of the law, and you just want to show that the work the QI work is getting done as required, but you're not going much further than that. Next slide. And so the consequences of doing that, if you don't do something well, there's always consequences, right? So the consequences of pro forma implementation is that the Quality Improvement Committee and the Quality Improvement staff will have less credibility and influence in the organization beyond dotting I's and crossing T's. So if that's what the Quality Improvement Committee exists at the county level. So if the sort of word gets out that what the Quality Improvement Committee and staff are worried about really is just getting the bare minimum done, then everybody else tends to follow that. This is all we have to do is give them the bare minimum, and everything will be fine, but nothing will get done beyond that. Quality Committee and staff will also have less credibility with external auditors. So it'll be real clear to, say, EQRO, for example, when they come in to do their quality reviews, if the committee is only doing the bare minimum, then they are probably not going to be too thrilled with that, and they may focus in a little bit harder on areas that they think aren't being done so well if they think the committee's not doing a full job. And then finally, it talks about the fact that cost-benefit ratio of the QI effort is limited. It's sort of like if you're going to have a whole bunch of good people working on quality on a committee level and being sure that the right data is being brought in and that regulations and standards are being met, why not get as much out of that as you can in terms of cost-benefit? Next slide. So finally, what does the Quality Improvement Committee need to be effective? One might say that this slide is a little bit basic, I guess, in the information, but for the committee to be effective, you've got to have an executive director who understands what the quality committee is about and will back what the quality committee needs. So if there are things that need to be done to improve accessibility and quality, and in the beginning there probably will be, because again, the requirements around accessibility and quality are new, and there probably will need to be some changes. You need to have somebody at the sort of top of the pyramid, if you will, and I'm not quite sure who they're referring to as executive director. It might be the head of health services or public health or something that will stand behind the work that the committee is doing and help bring about change that might be needed. A committee needs to be willing to respectfully speak truth to power within the agency. When you find things that need to change, the committee's got to have a voice to speak up to get those things done. And then finally, in the same way that you need to have backing from those who are in sort of higher places where they have the political strength or community strength to get things done, you also have to have good relationships with people working in the programs, people who work in the clinics, people who work in the programs that the county is contracted with, operations chiefs, middle managers, et cetera, who need to be persuaded to act on findings and recommendations when that's necessary. So you have to have good relationships going up the pyramid and down the pyramid as well in order to be effective. Next slide. So what we're going to talk about now is a little bit about the structure of a quality improvement committee. And these slides are really, when we talk about structure, they're really kind of discussion slides. They're slides that will give you information that we would like you to think about. There isn't a lot in the template that I talked about before in the attachment Z template that says, like the makeup of a county's quality improvement committee has to be X, Y, and Z, that you have to have certain people in that committee, for example. It doesn't give a lot of that sort of direction. So when we talk about what the structure of your county quality committee might be, these are a lot of what we'll be talking about are ideas. One of the things that I think there's a slide later that talks about this as well, but we want to talk about now, is the fact that on the mental health side, there's been mental health Medi-Cal for many, many years. On the substance use disorder side, it's only been for perinatal and medication-assisted treatment. So there's a lot more experience on the mental health side, and there will be a quality improvement committee in, I believe, every county that represents the mental health Medi-Cal needs for quality and access. I think the recommendation is that those people who are in charge of the substance use disorder quality issues would take a look at merging with the mental health quality improvement committee. They've been working at it for a while. They know how it all works. Rather than have two separate quality improvement committees within the county, it may make sense, and it may be a better use of people's time, and it may help to educate people right from the beginning to get the benefit of working with people in the mental health area to merge the substance use disorder quality committee with the mental health quality improvement committee as well. Next slide. The QIP requirements, quality improvement plan requirements. In good old attachment Z that we talked about before, it says that you should describe the county's quality management and quality improvement programs. And again, we're talking about these. This attachment Z is the template. So when it says describe the county's quality management and quality improvement programs, that means that in the application that your county made to the state to opt in, you've already done this, right? So this is this kind of language where you see the quotation marks is the boilerplate from attachment Z. And whenever you see that, it sort of says, we've already made a commitment to do this. We have already described our county's quality management and quality improvement programs. Next slide. And in that, you must have a description of the Quality Improvement Committee and its responsibilities in the existing mental health, or integration of the DMC-ODS responsibilities in the existing mental health program QI committee if you decide to do that. When this training is done in person on a face-to-face basis, there's a exercise that we do at this point in which I ask the participants to take a look at that handout again that you have for this training. And on page 12, I believe it is, there are, pretty sure it's page 12. There are, no, it isn't page 12. It is page 19 and 20. There are excerpts from LA County, Riverside County, and Marin County's responses to this question, where they describe how in their counties they're going to put together a quality improvement committee. And they talk about what the composition is going to be, what the leadership is going to be, what are the authority relations, who does that committee sort of report to, and how often is the committee going to meet. So since we can't really go through that exercise in this format, we'll tell you they're all a little bit different in the way they approach it. LA County, being LA County and being a very, very large county, has a number of departments that all participate in their quality improvement committee. The smaller counties do things in a little bit different way, right? They're not going to have probably as many people representing as many areas as the larger counties do. I think only one of the counties, I believe it's Riverside County, talks about what the leadership is going to be, who's going to be the head of the committee. They all talk about the fact that they're going to meet at least once a month or every other month and that sort of thing. But these are the kinds of things that need to be considered when you're putting together the committee. And it's probably already in your contract with the state as to how you're going to be doing that. Next slide. A description of the Quality Improvement Committee or integration of the DMC-ODS responsibilities into the Mental Health Committee. There's some more suggestions here for the QIC to include, but not required in the county's plan. Okay, so these are issues that need to be addressed in the actual implementation of the Quality Committee. These are things that you've got to talk about how you're going to do these things, but they're not actually in your county's plan. So one of the questions will be, will the Quality Improvement Committee establish practice standards? Is that something that the committee is going to take on? And if so, how will they be developed? And so in terms of practice standards, or what is the committee going to focus on in terms of standards? Is there going to be a focus on maybe integration of services with mental health and medical services? Is there going to be a prevention effort? Is they going to focus on collaboration and establish practice standards for the programs? What data sources will QIC review to determine whether or not standards have been met? What sort of data sources do you have within the county? We're going to talk about data sources later. Do you have existing within the county, and which data sources do you have to develop in order to be able to show evidence that you're following the quality standards? Who will review findings, or to whom will review findings be reported? So once reviews are done by the county of the county's programs, how are those going to get reported out? And who will develop and evaluate implementation and corrective action plans? The other thing that's a really important function of the Quality Improvement Committee, we'll talk about this in a little bit, is that the county committee does periodic reviews of how well that county is meeting quality standards, and will actually issue corrective action plans to programs to see that those are being done. All right. We'll talk a little bit now, and again, this is sort of discussion information. We'll talk a little bit about the QIC composition, about who might be on your committee and how you might put that committee together, and which people would be the most effective for committee membership. Question is, who might be ex officio members of the QIC? Ex officio sort of means that these people would be members of the committee by virtue of what their position is in the county or the larger organization. So would a county department director be a good member? Would the quality improvement administrator be a good member? We're going to talk about quality improvement administrators a little bit in a little bit from now. There's some information on that, and I think that every committee should have somebody who has a function of it being the administrator for the Quality Improvement Committee. An operations chief, finance director, IT chief, chief authorization reviewer, middle managers at specific service sites, administrators at partner agencies. I think since we can't actually discuss these, I will tell you what I believe, and I think what others have sort of reinforced on this is that somebody should be on the committee who is the administrator of the quality effort in the county. An operations chief is probably a good idea, but maybe not necessary. Somebody who knows something about finance, how finances work within the county, the contracts with the state and the contracts and rates, et cetera, with programs. It doesn't necessarily have to be a finance director, but someone who knows enough about the finances to be able to help the committee understand the financial impact of quality decisions is important. And the same with the IT chief. I don't know if that needs to be an IT chief, but because databases and data management are such an important item, such an important new item, and we'll talk about that in a little bit, having someone on the committee that understands what the major databases are in the county and how those work is probably a great idea as well. Authorization reviewer is almost necessary, I think, to a quality committee's work. Middle managers at specific service sites are a good idea, that you have people who are at a level where the work is actually being done in clinics and programs are represented as well. And possibly the administrators of partner agencies as well would be helpful. Next slide, please. And then it talks here, or asks here the question about who might be selected members of the QIC. These would not be the ex officio members, but people that you might just pick at large to be on the committee that might be helpful. Service staff representatives. Again, I think it's a great idea to have people who are actually doing the work on the quality committee, because they can really help a quality committee in making decisions. Let's say, for example, that the Quality Improvement Committee notices that access to programs is not as timely as it should be. Timeliness in getting people into treatment is real important under the ODS. We'll also talk about that in a bit. And let's say that's not working so well, so the Quality Committee decides to introduce a couple of policies that will improve the front end of the access process, so that when people first contact the program to get access to that program, that there is staff there 24/7 to talk to people who want to come into the program. Somebody from a program will probably be able to tell them that that's way too expensive, that they can't afford to have somebody there 24/7. So having people from the programs on the committee is a good idea, because they know on a very practical level what's possible and what's not possible. Consumer representatives, family member representatives. When we've discussed this in-person trainings, there's a lot of different opinions about whether it's helpful to have consumer representatives or family member representatives. Some people feel that they spend an awful lot of time in committee meetings with consumer representatives, oftentimes having extensive complaints about what's going on. Same thing maybe with family member representatives, that they take up an awful lot of the time of the committee, and maybe more so than they contribute. But you pretty much have to have some input from the people who are receiving the services. You've got to be able to be inclusive of your consumer population. They have to have a voice in what's going on. If nothing else, if you don't have that, and then there are complaints about the way the system is working, then you're going to get the criticism that that the counties and the programs don't care about the consumers. They don't care about those people who are entitled to services. You have this committee that's made up only of county people or only of program people. And so having consumer representatives, family member representatives, folks like that on the committee, I think is a good idea. And by the way, with consumer representatives, you don't necessarily have to select actual consumers. You might have, let's say you have a homeless outreach program in your area, and you have a significant number of homeless people coming into treatment, or wanting to access treatment. You might have somebody from that homeless outreach, maybe a staff member, who knows what the consumers have to say about how difficult it is maybe to get into treatment, be the representative rather than the actual consumers. It might be more effective to go that way. And then finally, should you have a risk management attorney or a county council representative? I think that probably depends a lot on the number and level of complaints that you may be receiving about the way access is being handled. Next slide. Okay. Talk a little bit about the QI administrator's role. By the way, we're going to have 2 or 3 slides here talking about a QI administrator's role, and there is nothing that says in the template for opting into the ODS that the Quality Improvement Committee has to have an administrator. But as I've said before, I think it's a really good idea that there is one person who has the responsibility of keeping things organized and coordinated from one month to the next, so that things are moving along and progressing well. If you don't have one person who has that responsibility, then I think, as we all know, things tend to not get done so well. And how much time you can have someone devoting to a QI administrator's role probably depends on the size of your county. If you have a large county and you have a budget that will manage it, having a full-time QI administrator is probably a good idea. As you get smaller counties and less money available for that sort of thing, then you may have a QI administrator's responsibilities being part of someone else's. You might have a compliance officer or somebody who has also the responsibility of being a QI administrator. But it isn't required. But the responsibilities of a QI administrator are important, right? What this slide has, that you have in front of you, shows a sort of broadly defined approach in which a QI administrator would have very few actual tasks to do, but a lot of responsibilities of ensuring that the work is getting done, the outcomes are happening, that the mission of the committee is being handled, and that things are well prepared for accreditation, medicality, QRO reviews, and that sort of thing. So the responsibilities are high, but the tasks are few. And again, this would be, I think, in a fairly large county where you'd have a full-time QI administrator. The next slide is a more narrowly defined approach in which there are a lot of tasks. This would be in a county in which the QI administrator would actually be doing a lot of the hands-on work of the committee, work that the committee would need to see gets done. The QI administrator would actually be doing that, conducting chart reviews, creating, administering, interpreting survey data, writing, receiving, distributing reports on agency activities. So there'd be real hands-on work, and the responsibilities would be important, but not quite as important as those with that broader approach that we just talked about. I think that probably in most counties, what the QI administrator is doing probably is a lot closer to what's on this specifically defined approach rather than the broader approach. And again, it's not mandated. It's not required by the standard with the special terms and conditions or by DHCS or ECRO, but probably a good idea to have an administrator. Next slide. So what do you need to have an effective QIC? Some of this stuff probably seems pretty obvious to you, but I think we ought to go through it as well. To have an effective QIC members, the effectiveness of the QIC members is likely to vary according to basically how much they know, right? Professional or technical preparation and the practices being monitored, that they know sort of, for example, if people on the committee don't know much about how ASAM works and the clinical requirements of evidence-based practices, for example, and those kinds of things, then that's not going to be too effective. Professional and technical preparation in QI procedures, research methodology, and data analysis. You have some people on there who actually are able to do data analysis. A commitment to continuing education, and then relationships with operations managers and persuasive people skills. So when things come up that need to change, that there are people on the committee who are able to talk to, let's say, program people, for example, where the changes need to happen, and persuade people to perhaps take a different path. I don't know, some of this information is just old basic kinds of stuff. You notice this bullet on here on commitment to continuing education. And it seems a little bit odd. It's sort of like, why should quality improvement committee members have a commitment to continuing education? It's sort of a discussion question. And the answer to that is that there is a lot going on in the field right now that's being demanded in the field, but stuff that's happening that is changing all the time. The technology is changing all the time. Data collection, data analysis is evolving all of the time. And people on the committee should have a commitment to their own continuing education, as well as seeing that continuing education is provided for the people doing the work as well. I think this is just sort of a nod to the fact that we live now in a world where things are changing quickly in the treatment world, not only from a clinical perspective, but in terms of what we want to know about how good a job we're doing and what our outcomes are like, that it requires a lot of continuing education or a commitment to continuing education. Next slide. What does the Quality Improvement Committee need to influence quality of care? You got to have explicit quality of care standards. Some of those are provided by EQRO, the External Quality Review Organization. I said before, this is the organization that will review counties and programs to see primarily that quality and access are available, are being implemented, have been implemented and implemented correctly. I really want to encourage you all to take a look at, not right this second, but to take a look at the CalECRO website, www.calecro.com website. On that website, you will find things like review protocols and a lot of information about what the reviews will look like. What is EQRO interested in when they come out and review programs? What are they going to be looking at in detail? Okay, that's on, a lot of that information is on that website, and I would urge you to take a look at that when you get a minute to do that. There is a sort of a printout there on that website, or a schedule on that website that's entitled Drug Medical Organized Delivery System Year 1 Performance Metrics, for example. And it's really, I think, very helpful in terms of what exactly the EQRO review will include and what it is they want to look at. For example, in the area of access to care, one of the standards is the timeliness of first initial contact with a client to the first face-to-face appointment. So what this document tells you is exactly how many days that should be, or what number of days that they would like to see, and what data will they be looking at in order to determine how fast that's happening. So they'd be looking at things like county access logs, but it actually says on this document exactly what it is that they will be looking for to show evidence that timely access is happening. So I'd really encourage you to take a look at the Cali Pro website and see what you can get there that would be helpful. Some of the care standards are provided by DHCS. And if you want to get the information from DHCS on what's required in terms of the DMC-ODS, go to the DHCS website up in that wonderful box in the corner. Type in DMC-ODS, and it will take you to a page of just about everything that you will need to know from the DHCS perspective on quality of care standards and everything else about DMC-ODS that they're concerned with. And then some of the care standards should be developed within your organization to address local issues. So if there are things that are happening within your county or within your area that look like they would require a quality of care standard, then those should be developed by the Quality Improvement Committee in their role as creating policies for things that need to happen. An example of a local issue might be that if you find that, let's say, you have co-ed intensive outpatient groups, and you have a fairly high percentage of either women or men who might be dropping out of those groups, you might determine from talking with them that you need to have gender-specific IoT groups, for example. And so you might create a policy or a standard around having gender-specific treatment in your county. So some of the quality standards will be given and by EQRO or DHCS, and some of them may be developed by you. That issue about gender-specific IoT groups, I mean, that's a quality issue. That's an access issue, because what we're really saying is if there's, let's say it's the women who are dropping out of the group because they're not comfortable in a co-ed group, then they're not having access to intensive outpatient treatment in the way that they should if it isn't gender specific. Hope that makes sense. But when you're solving quality or access problems locally, you may want to actually develop a standard around that so that everybody's living by that. Right? The other thing that will help influence quality of care is if the committee has access to the codified manuals used to establish evidence-based practice methods. The codified manuals pretty much are available on NREP. If you go to the SAMHSA website and you type in NREP in their box, it will bring you to a page on the evidence-based practices, the ones that have been approved, and that will help the committee understand what it is that constitutes the correct implementation of the various evidence-based practices. And then finally, the committee should have authorization to gather information throughout the agency. So everybody in the agency should be on board with the fact that there is a quality committee and they are going to be looking at certain quality standards and access, and they need to be able to gather information. This is something that has to happen. It's like programs and clinics and whatnot can't put off the committee, and the committee needs information and they need data. They need to be able to get that, and there should be that understanding that the committee is authorized to do that. Next slide. What is the knowledge base of the effective QIC member? Not all members, obviously, are going to have all of these things. What we're really talking about is that somewhere on the committee, there needs to be a good knowledge of what the quality processes are, like chart reviews and data collection, data management, data analysis, report writing. What are the processes you follow in order to determine whether quality is happening, the external standards and regulations, the organizational structure, dynamics and development, clinical practices, et cetera. And again, somewhere on your committee, there have to be people who are strong in all of those areas. There won't be anyone who knows all of those things. Client needs and client rights are important as well. Next slide, please. Okay, balancing authority and responsibility. This talks a little bit about what kind of, shall we say, strength or power does the QIC committee and the QI administrator actually have. This first slide, there are two slides there. One talks about authority and one talks about responsibility. It says, what will the QI administrator be held responsible for? And this, again, is a discussion question. So I'd ask you, is it assuring that standards and regulatory requirements are met? Is that administrator or the committee responsible for the quality of services, staff compliance, quality of documentation, validity, reliability of data and reports, fair and effective corrective action plans? The answer is that the Quality Improvement Committee or the administrator don't really have their responsibility, actual responsibilities are not terribly broad. In this case, they would be responsible to see that the data and reports that are being generated are accurate, and that the corrective action plans that they're issuing are fair and effective, the sort of last two bullets. They're not responsible for quality of services. That seems sort of odd since this is the Quality Improvement Committee. But whether or not a contract program, for example, is working at the level of quality that they should be working on, that's not really the committee's responsibility. It's the committee's responsibility to let them know what the standards are, but they don't have the responsibility or authority to go into a program and make actual changes, right? They can tell the programs what they need to do to make those changes, or that they need to come up to a particular standard, but that's not something that they have the responsibility to actually change by virtue of the committee or the QI administrator. Next slide. This is a balancing of the authority and responsibility. This has more to do with the authority. Would a QI administrator, for example, someone on the committee, any member of the committee, have the authority to direct the practices of middle managers, practitioners, service staff, clerical support staff, other QIC members? Anyone? The administrator and committee actually, again, have very little authority. They do reviews. They let people know what the standards and regulations are and what they need to come up to. They can tell them what databases they need to have in order to produce the information that the committee needs to look at. But in terms of actually changing practices, changing the level of work that's being done in the programs, not a lot of authority there. Okay? And then the next slide, still on the authority and responsibility piece there, is, will the QI administrator have independent authority to report uncensored findings upwards to an executive director, to middle managers or practitioners, external organizations? In all likelihood, the QI administrator would not have independent authority to report uncensored findings out to anyone. The QI administrator's role would be to filter the information and uncensored findings, for example, to make sense of those findings before they're utilized as real report findings. Next slide. Okay, so now we're going to get into the fun stuff, the QIC content. What must be addressed by a county's quality improvement committee? What is it exactly that the committee needs to do? And this is, I think, what people are sort of looking for in terms of what is EQRO going to be looking at in their reviews? What is it exactly that we have to be able to show we're doing? And by the way, if you did the quality assurance A training, a lot of this content information was covered in that, but we're going to go over it again. There are 7 mandated QIC content issues. These are the 7 things that the QIC is going to look at, right? So you have your committee. We talked about the content of the committee, or the structure of the committee, and how committees are put together, who might be members of that committee, what their responsibilities are, what their authority might be. And now we're going to talk about what it is that they're actually going to be looking at. 7 mandated areas are, and by the way, these are all in the handout that goes along with this training. Timeliness of first initial contact to face-to-face appointment. Okay, this is timely access. From the time someone calls the access line to the time they get their first face-to-face appointment is something that is important and is going to be reviewed. Timeliness of services of the first dose of NTP services. How fast can someone actually partake of the NTP services? Access to after-hours care. What is the availability of care after hours? Responsiveness of beneficiary access line. Right? When people call the beneficiary access, we're going to talk about it in a little bit more detail, what you need to be able to do to show that these things are working well within your county. But a responsiveness of the beneficiary access line, when people call the access line, that they're not disconnected, not put on hold forever, that they're actually able to talk to someone. Strategies to reduce avoidable hospitalizations. This is a requirement, and it's something that the QRO is interested in looking at. What might be a strategy to reduce avoidable hospitalizations? If you are interested in reducing avoidable hospitalizations, you might have an agreement with the local emergency room or rooms, so that when people come into the emergency room and they're under the influence and they're addicted and they're showing signs and symptoms of pretty serious, being pretty seriously addicted, that if they're looked at by a physician and the physician determines that this person ought to be in a controlled environment, but they don't need hospitalization, that there's an agreement between that emergency room and a program, a residential program, to be able to take that person in. That would avoid the actually hospitalizing that person. If there wasn't a program to take the person, then they'd have to go to the hospital. It's a better choice because it gets people into treatment, and it's a less expensive choice as well. Strategies, I'm sorry, I almost repeated that. Coordination of physical and mental health services with waiver services at the provider level. All right, so you've got to have some coordination or integration of services people would need for physical health or mental health services at the provider level, so at the program level where people are receiving services. That if someone is receiving substance use disorder services, that there is coordination for their mental health needs, should they have them, or physical health needs, should they have them as well. Assessment of the beneficiaries' experiences, some way of doing a survey. It might be a survey, it might be looking at the number of complaints, for example, but somehow one of the things that EQRO will be interested in is what is in a particular county, what is the experience that people are having in treatment? And then finally, telephone access line and services in the prevalent non-English languages. There's a very strong sort of access issue around having not only access line, but services as well in what they call threshold languages, right? So whatever in your county is a threshold language, people have to be able to get help through the access line and ultimately have services as well in those non-English languages. Talk about that in a little bit more detail in a second as well. Next slide. 4 mandated types of data to be reviewed by the QIC at least quarterly. So your Quality Improvement Committee is going to have to look at number of days to the first DMC-ODS service at the appropriate level of care after referral. Somehow you have to have data available that will tell them when people make their first call to when they actually are receiving services. What is the number of days to do that? Existence of a 24/7 telephone access line with prevalent non-English languages. We talked about that. That has to be reviewed at least quarterly as well. Access to ODS services with translation services in the prevalent non-English languages. And the number and percentage of denied and approved authorization requests. So those 4 items need to be looked at, reviewed at least quarterly by the QIC, and I think it's pretty obvious to say one of the reasons they want them reviewed quarterly is that these are important, very important access and service areas. And the reason for them being quarterly is that we need to know pretty much at any given time that people are getting that access, right? And the changes are happening, that new processes are being implemented that are going to help that to happen if it's not happening. Next slide. What database will your QIC access in order to determine number of days between referral assessment and the first service follow-up appointment? And this is sort of the length of time from when someone is an applicant, when they make maybe their first call on the access line to when they get their first follow-up appointment, first face-to-face appointment with a service provider. And one of the questions here would be, how are you going to be able to show evidence of that? What database will you use in order to determine that? Okay. The database would show the number of days between the time when a beneficiary first becomes an applicant and then a client. I think that a lot of the database issues that have to do with timeliness of getting into treatment, of getting services after one makes their first call. If a county's on and programs are on electronic health records, that's a database that covers an awful lot of this stuff. You can go back to when, if you open, for example, a case when somebody calls on an access line, you would have that date of access and you would have the date of the first follow-up appointment as well. Both would be in the health record. If you don't have that, then you have a little bit different problem. It's sort of like what sort of records are being kept. If it's not a database, what sort of record of whatever sort are being kept at the access line level, so you know when people have called and when you've made a referral on what date, and then programs would have to have their own database or their own way of showing evidence of when that person was there. Point here is, when the question is asked in a review as to what kind of job are you doing in terms of the timeliness of getting people into treatment, you've got to have some sort of database that shows what those lengths of time are. Next slide. What database do your QIC access in order to determine the availability of 24/7 access line with prevalent non-English languages? And how are you going to get that information? That would be a question. That would be a discussion question if we were doing this face-to-face. I would suggest that maybe people on the QIC committee or QI administrator may call that 24/7 access line at different times. Have people call in those prevalent non-English languages and see if the services are indeed available or if there is a service to do translations. Next slide would be what database would you, it needs to sort of continue on, what would your QIC access in order to determine access to translation services in the prevalent non-English language? So is there a translation service? And does it work well? Are staff trained in order to use the translation service? And then what database would your QIC access in order to determine a number and percentage of denied authorization requests in the time period of approved or authorized or denied authorization requests? And again, the point here is that that these are the things that are important in terms of timeliness of service. And whatever those regulations or standards are, you've got to be able to show as a provider, as a county or as a provider, that you have those dates, that you are doing those things in a timely fashion. And one way or the other, you need a database, some record that keeps track of those dates. And I would suggest that that's not a difficult thing to do. It's something that you need to be aware of. You need to be able to be sure, even if it's old-fashioned pencil and paper stuff. If you don't have databases, you can still come up with the dates that you need in order to show that you're providing timely access. Okay. Next slide. Talk a little bit about authorization. This goes back to the continuum of care that we talked about in the beginning. I think we need another slide, Yvonne. This goes back to continuum of care that we talked about back in the very beginning. That what one of the things that's promised in the ODS is that there will be a continuum of care that people move through in order to get into the right medically necessary level of care, and that it is a client flow sort of process. People are referred to a program, usually from an access line. They are assessed, and the assessment uses, of course, ASAM and a diagnosis to determine what the level of care is. That level of care is then authorized, the person is placed in care, and then at the appropriate time, they may be transitioned to another level of care. All right, so authorization and having authorizations is, of course, critically important in terms of residential care. There needs to be actual authorizations by counties for people going into residential care. Counties will also review the data, the information on client records that shows why a person was placed in another level of care, and that becomes an authorization as well. So client flow and authorization is important stuff. And it's included also on the next slide. It's part of the utilization management program that's also in every county's contract with the state that has opted in. Right? The utilization management program really is key in being sure that the client is accessing the right level of care. That's what utilization management is all about, is making sure that clients, patients are being moved about and that they are in at any given time the right level of care based on their assessment. Okay, next slide. Next slide is another poll question. It has to do with medical necessity, which we're going to talk about in a little bit. But the primary purpose of establishing medical necessity under the ODS is to save money by moving clients to less intensive treatment, or ensuring that ensuring that the client is in the level of care that best addresses her or his needs. What do you think the correct choice is there? Okay, you got the answers to that. Excellent. Everybody got that right. 100% said ensuring the client's in the right level of care that best addresses his or her needs. By the way, some questions have come in while I've been talking here. I'm going to see if I can pick off a couple of them here quickly and answer them for you. One of the questions is, define the difference between the initial request for services and initial contact. There is no difference. I think they're used basically in the same, to define the same thing. When someone calls an access line, that certainly is initial contact and usually involves a request for services. So I don't know if that answers the question or not, but they're basically the same thing. There is no real difference. And the second question was, when does the clock for timeliness to service begin? It begins with that first contact call, right? One of the first piece of the timeliness question is the time from that. I think we just talked about that. The time from the first contact, the first call, to when they get their first face-to-face appointment, which is not a treatment appointment, but the time that they make their call, they're referred to a program. When they first make contact with that program, then that's where timeliness for service starts. So I'll try to get back to some of the other questions in a little bit. Well, question number 2, you all did very well on that. You should congratulate yourselves for that. Utilization management. Next slide. Utilization management. Counties will have a program assuring the beneficiaries have appropriate access to subsidy services. Medical necessity has been established and the beneficiary is at appropriate ASAM level of care. And the interventions are appropriate for the diagnosis and level of care. And again, going back to when we first started talking about, this is one of those items that's promised by the feds. And the source of this, it says on the bottom, is part of the state terms and conditions. This is something that has to be done. Medical necessity is established. And this is a quality issue, primarily a quality issue, that the beneficiary is at the appropriate level of care. And the interventions are appropriate for whatever their diagnosis and level of care is. As we talked about in the beginning, medical necessity will do something else for the system, hopefully, and it's addressed by CMS when they implemented the CMS at the federal level, when they implemented the ODS, was to basically say that if medical necessity is closely followed, that it will have a positive financial impact on the system, because care will be a little bit less expensive than it has been in the past. I guess an example might be that in the past, if you if you had somebody who was approved for 60 days of residential care, for example, and they're put into 60 days of residential care, and that's where they stay for 60 days, right? And nobody during that 60 days necessarily looks at whether residential care is medically necessary during that whole time. Let's say the client begins to, after 20 days, begins to be doing very well, fully involved in the program, families involved in the program, everything is going well. What should happen at that point is that some level of ASAM should be done by the counselor. Might be not the full ASAM necessarily, but you want to be able to look and see, is this person, is residential care still medically necessary? Can this person move to a less intense level of care? And if the person then does move to a less intense level of care, then that's going to put the person at the right level of care, but it's also going to be less expensive. This whole area of utilization management is something that I call the 3 R's. I want the right person is in the right program at the right time. That's what utilization management is all about. So you have an individual, you have a client that you know what you need to know about them. In other words, you know where medical necessity is for that person. You've done all the evaluation, all the assessment, so you know the right information, so you can put them at the right program, the right level of care, and that if they need to be moved at any time, if it looks like it's appropriate to move them at any time. And by the way, that movement in the continuum of care goes both ways. You may have somebody in intensive outpatient who is not doing well and slipping, and maybe an ASAM might tell you they need to go the other way. They need to be in residential care. But you have the right person in the right program at the right time. That's what the sort of goal of utilization management is all about. Excuse me. Next slide. County shall have a documented system for collecting, maintaining, evaluating accessibility to care, and waiting list information, including tracking the number of days to first service at an appropriate level of care following initial request. And that whole thing about accessibility to the right level of care is something that's, the proof of that, if you will, or the evidence that you're doing that is going to be in the assessment or charting notes to the person in treatment. We'll tell reviewers whether folks are in the right level of care. Next slide, medical necessity. In order to establish medical necessity, I think this is probably stuff that you all know pretty well by now. If the client has a DSM diagnosis for a substance-related and addictive disorder, and they also meet ASAM criteria for whatever your assigned level of care is. And again, if you look at the bottom, this is a DHCS special terms and condition item. Medical necessity is not something that is an option. It is something that you need to be able to do, and it certainly will be looked at probably by both DHCS reviews and ECRO reviews. Next slide. DMC-ODS medical necessity is different for Medi-Cal necessity for special mental health services than for substance use disorder. I would ask you to go to, rather than spend time on this right now, I'm sorry, choking up here. If you would look at page 27, not right this minute, you don't need to, but if you look at page 27 and 28 of the handout that you have that goes along with this training, it gives a fairly simple but accurate sort of overview of what those differences are. Right? It isn't something we need to spend a lot of time on right now, other than to say that for those people who are been in the mental health area, that the medical necessity, establishment of medical necessity is different on the substance use disorder side, and people should be aware of that. Next slide is a description of the QIC will address monitoring of accessibility of services. And address, by the way, doesn't mean that the Quality Improvement Committee will mandate it. It means that the committee will monitor and recommend services if they're needed, right? But accessibility is not merely available. And throughout the literature on ODS and all the quality stuff that's written about accessibility, it's a very, very important part of the ODS that people know about services, that they know the services are available within the county, how to access them, that they can access them in the right language, that they can access them if there are disability issues, but the programs have to be fully accessible. And that is an item that is going to be reviewed. So the QIC needs to be looking at the ways that they can show evidence of accessibility at any given time. The next slide is accessibility is not merely availability. People need to know about it. All right, so one of the things that will be looked at will be what kind of information is put out on the program, on the services, how is it put out, where is it put out, so that people know that there's an access line, that there's a way to begin to access services and what those services are, that people can get to it, that there are not geographic or transportation issues that they can't overcome, that disabled people can enter and use a facility, that staff speak the language of people coming to the program or translation is available, and it's open when clients can come to it, right? Those are the accessibility kinds of issues, or a good definition of accessibility. And, most of these look like, well, these are pretty easy. A lot of this stuff maybe you do already. Probably there is some way that programs are advertised, if you will, that there's information out there on a website in every county that talks about what the programs are. Is that in threshold languages as well? Are there ways that people who aren't able to access websites, who don't have computers, are able to find that information? Got to put that information out in as many ways as you can. And then people have to be able to get to the services, and they're provided in the right language. The last bullet, it's open when clients can come to it, has been a bit of a problem for some programs, because it sort of forces the issue of being open more hours than you may have been in the past. If someone absolutely can't come to outpatient during what you might consider normal working hours of 8 to 7 or something like that, 8 in the morning to 7 at night, and maybe they can make the point that they can only come on weekends, then have an obligation somehow. The QIC has an obligation to look at that and try to find a way that maybe one of the programs, at least in the county, is able to do, weekend work, weekend outpatient, drug-free work, or intensive outpatient work. So it may stretch programs to begin to look at different ways of providing services, different times of the day or the week, in order to make them accessible. But accessibility the ODS is sort of hard-headed about this accessibility issue. It's like they say these are these programs are entitlements to people who are Medi-Cal eligible, and the programs absolutely have to be accessible, not just available. The monitoring of accessibility of services outlined in the Quality Improvement Plan will at minimum include timeliness of first initial contact and face-to-face appointment. I think we covered this already. Frequency of follow-up appointments in accordance with individualized treatment plans. right? So there are follow-up appointments when the treatment plans call for those. Timeliness of services of the first dose of ATP services and access to after-hours care. In the plan that counties wrote to the state to opt in, they didn't have to state how they were going to do these. So these are items that counties are needing to look at in order to figure out how they're going to do these things. But they didn't have to spell out in their proposals, if you will, to the state is exactly how they were going to do it. They just had to say, we will do these things. We will be timely in that first initial contact. There will be timeliness of services and access to after-hours care. Okay. Next slide. And a kind of a continuation of that. We'll also need to look at responsiveness of the beneficiary access line, strategies to reduce avoidable hospitalizations. These go back to those 7 items that we talked about before: coordination of care at the provider level, or integration of care, if you will. An assessment of beneficiaries' experiences, including complaints, grievances, and appeals, and telephone access line. What I would suggest is if you're relatively new in terms of implementing the ODS, that you really take a look at these items and just make sure that, first of all, that you're doing them, or that you're capable of doing them, and what do you have going in terms of, if not databases, some way of showing evidence that these are available in your counties. Next slide. They give you here, and these are examples, by the way, that come from the EQRO. All right, these are in, there's a key component standards and review tool, which, by the way, is on that EQRO website that I talked about earlier. And what they give you here are some strategies for improving access. And sort of, again, everybody understands that the things that are required under the ODS in terms of quality and in terms of access aren't things that programs are necessarily doing right now or before ODS is implemented. They're things that are going to have to do, and they need to start doing. And EQRO wants to be as helpful as possible in helping programs to get there. So one of the things they're suggesting is adding staff position, hours, or contractor services with needed skills in specific geographic areas will help to provide access. Provide services nights and weekends, so we talked about that. Allow flex hours, part-time staff, per diem staff, figuring other ways to staff your programs that are going to help get services provided at times when people need them, need to access them. Provide special programs such as loan forgiveness, structured internships to bring in new clinicians to the workforce. When I've done this training in person, we've got a few chuckles out of that one. That not an awful lot of counties or programs can do things like put out programs for loan forgiveness in order to attract maybe licensed people into the workforce. Use technology to enhance access and training consultations such as video conferencing, translation lines, telemedicine, psychiatry, and that sort of thing. I think the first 3 items here are all things that you might want to take a look at. But staffing is an issue. You know, when you have to provide as much access as you can for services, it's probably means that it's going to be on days and hours that you haven't traditionally been open, and that may well mean that you have to be a lot more flexible in the way that you staff to those. You know, if you're just doing a group on Saturday and a group on Sunday because that's a need of access, you can't hire somebody full-time to do that, right? You're going to need somebody who do that on an hourly or part-time basis. So you got to have sort of a different headset in how you staff to be as accessible as possible. Okay, next slide is poll number 3, collaborative relationships, which we're going to talk about in a minute. Collaborative relationships are required, and by the way, they are. There's a section in the standard terms and conditions that talks about collaborative relationships that programs have to have. in order to qualify, in order to be sort of opted into the ODS. And the question here is, why are they required? Why are collaborative relationships important? These would be relationships, with like other providers, other agencies, other services, both private, public sector services in a community. It's required that you have those kind of relationships. Why is that? Do they enhance access to care because they provide ancillary service needs, other service needs than the ones that you have, that your clients may have? That they improve overall quality of care, or all of the above? I'll give you a minute to answer that. I can't see that. Well, you all passed again. 100% of the answers say all of the above, and collaborative relationships help in all of those ways. They enhance access to care. How might that happen? Let's say you have a relationship with urgent care. The urgent cares and emergency rooms throughout your county, and a real active collaboration with them to move clients back and forth to get them into treatment easily. And you have MOUs and whatnot, and ways of doing that. That would help enhance access to care, help provide ancillary service needs. So if there are mental health needs, for example, that your clients have that you don't have as a service need, but you have a collaborative relationship with someone who does have them, and helps there. And that would help, of course, improve the overall quality of care that somebody has fully integrated physical, mental health, and substance use disorder nurses. So good, pass one with 3. So next slide, on collaborative relationships. The statement made in the in the template is the DMC-ODS has developed strongly collaborative relationships with the following providers to enhance access to care and meet a broad array of client ancillary service needs. This is a requirement of the ODS, and it doesn't have to be monitored, by the way, by the QIC, but it is a requirement. It's something that you need to do, but it's not something that the QIC has to monitor on a regular basis. It is something that will be looked at from external reviews, however, to see that you have collaborative relationships. Next slide. I think there's a couple of slides here that talk about what the suggestions are for collaborative relationships. If you don't have them already, with primary care providers, clinics, hospitals, emergency rooms, mental health programs. These are all pretty obvious things, I guess. Child welfare, human services, educational system, criminal justice. Next slide. Public health, medical health plans, community-based organizations, Meals on Wheels, faith-based organizations, vocational training and job placement, housing authority, and self-help organizations and networks. You don't really need to have specific collaborative relationships necessarily with self-help organizations, but they should be ones that you're well familiar with. So these are all collaborative relationships that might be helpful in meeting all of the needs of your clients. The next slide talks about evidence of collaborative relationships. So by evidence, it means, and this is also from the EQRO Key Component Standards and Review Tool, what would they consider to be evidence of the fact that you have collaborative relationships? They come in and they want to see if, County X or Program X have collaborative relationships. They might be looking for shared grants that you have. You might have a shared grant with another program to provide a particular service, a particular group of services. It may be in your planning and implementation reports that you're working with other agencies. MOUs with organizations are really important, and it's something that EQRO reviewers like to see. The fact that you actually have an agreement, a specific agreement, doesn't have to be a contract. An MOU is okay, even a letter of agreement with other programs that you will do certain things. So that when the time comes to have those things done, you know, if another program says, yeah, we will do, we're a medical program, medical clinic, and we will do physical exams on your on your clients, and then you'll do something for us. That if that's in writing in terms of an MOU or letter of agreement, it's a much more firm. It will be a much better collaborative relationship and more firm. Interagency referral protocols. You don't have an MOU with them, but you do have something in writing that talks about how you're going to make referrals back and forth in terms of protocols is also good. Joint initiatives, sort of like shared grants, things that you're doing together. A program and the local United Way are working together on prevention programming or something. Committee meetings you have in which you're working with and meeting with and working with other agencies is another way to show evidence of that. And then on-site review observations, such as staff and partners reporting and give examples. So if the reviewers come out and they would either observe or sit in on sessions where you could talk about examples of how you have integrated services with others in the community. Next slide. Another obligation here with a QIC is to track no-shows, cancellations, and first appointments. DMC-ODS tracks and trends no-shows, cancellations, and ideally first appointments offered. The QIC doesn't have to do the tracking. There may be, if there's somebody else in the organization, might be an evaluation unit, a contract monitoring unit, an IT unit might do that, do the actual tracking, that's fine. But the QIC would do the data analysis on that tracking to sort of make sense of it. And what are you trying to find out here? If you go to the next slide, in tracking these no-shows, cancellations, and first appointments, what you'll want to look at, and again, this is straight from the EQRO review tool, so this is the kind of stuff they're interested in. What to track by program unit, the rate of no-shows and cancellations, right? Of those people who maybe call the access line, they're referred to program X. How many of them are no-shows? How many of them actually cancel, or do they just no-show? What seem to be the barriers to care of those people who cancel? Why is it they cancel? What's the impact of no-shows, cancellations, and barriers on clients? And what are the types of no-shows? Do they actually initiate? Does the client initiate the no-show or cancellations, or is the staff initiating the no-shows or cancellations? Why are these things happening? What is it? Because this is, again, an access thing. This is a timeliness to treatment. One of the things we're really concerned about with the ODS is when people need help, not only do they get it, not only is it accessible, but it's accessible in a timely fashion. So this kind of information about what's happening on the front end of the referral process is important stuff. Next slide, please. More evidence of tracking. What else will the reviewers look at? Routine reports, special surveys that might be done, focus groups. They'll review records of automated and clinical staff callbacks. Do you do that sort of thing? Do you call people back? Do you call people to remind them about programs? Do you send them, or appointments? Do you send them text messages to remind them of appointments? What is it that you're doing to try to improve that? And what are the barriers? What have the barriers been? Next slide. Evidence-based practices, as you know, under the ODS, programs should be using 2 of, I think it's 6 specific evidence-based practices that are outlined. So the question is how are counties going to ensure that providers are implementing at least 2 of the identified evidence-based practices, and what action will be taken if providers found to be in non-compliance? So what are we doing to ensure that providers are implementing at least 2 of the identified evidence-based practices? Go to the next slide. Evidence might be evidence of the staff training to use specific EBP. So EQRO comes in and they're looking at this and they're going to say, one way we'll know that you're serious about evidence-based practices, your staff is trained in MI, if that's what you're using. They may want to observe staff with the clients. They may want to observe, group or individual counseling sessions to see if there's evidence of the evidence-based practices. They probably will not look at fidelity studies, at least in the first couple of years. Doing evidence-based practices to fidelity means that you're doing it exactly, implementing exactly the way that it needs to be implemented. And there's a couple of things going on with that right now. First of all, it takes a while for programs that are just beginning to use evidence-based practices to get to a point of fidelity. There's also a challenge to the fidelity studies that is going on right now. If you, again, go to the NREP page on SAMHSA, you will find a letter from the current head of SAMHSA saying that they have serious questions about whether the evidence-based practices that have been recommended and approved as evidence-based practices are really all that good or not. And so this whole issue of fidelity is probably up in the air right now. So you can be sure that EQRO is not going to come in with the fidelity requirements and look at those against what you're doing. Reviewing charts for descriptions of staff interventions that come from the evidence-based practices is another way to show that you're doing these things, but fidelity will probably not be required. Next slide. Because we're short on time, I'm not going to ask you to fill out this poll number 4. It really is in here because we're going to talk about data for just a couple of minutes, and data concern with data collection, data analysis is new, and it's kind of a big item for programs to worry about. So data plays a key role in the ODS as a way to prove that certain regulations are met, such as time of treatment, prove that timely access exists, prove that ODS is using data to inform management decisions, all of the above. All of the above. The third item on here of use of data to show that that counties and programs are using data to inform management decisions is really sort of important to be able to show that we are looking at data, we're analyzing data, and we're taking the results of that to make the changes that we need to make to either meet quality standards or improve on quality standards. Next slide, please. And it says here a variety of, I'm trying to hurry up here, we're just about out of time, but a variety of data sources are used to inform management decisions and guide decisions. Next slide. Databases that provide evidence that that they are being used in a functional way. These are the sort of databases that EQRO will be looking at: claims data, timeliness data, outcome data, CalOMS data, call center data, that sort of thing. So you want to sort of try to match whatever data sources you have that can be used as evidence to prove that you're meeting certain quality standards. That's kind of what this is about. And again, it's a big deal on the substance use disorder side. It may not be for mental health. I'm not really clear about that, but you know, CalOHMs and DATAR were about the only things that we needed to worry about in the good old days prior to ODS, I guess, in terms of databases. That was it. And those were pretty easy to keep up with those. But now data is the way of showing timeliness, right? It's the way of showing that ASAM assessments and medical necessity is being met. So having databases, being able to evaluate and analyze them is really important stuff all of a sudden. Next slide. Grievances and appeals. And I'm going to leave this up to you again because we are getting short on time to do a little bit more research on your own. But grievances and appeals are part of the quality effort. And if we go to the next slide, grievances and appeals, the grievance and appeals process is different under Medi-Cal than it is under the sort of substance use disorder programs that were not Medi-Cal approved in the past, such as residential care, for example. For those programs, it used to be okay to have an internal grievance and appeals process, right? And you told the client when they came into treatment what their rights were, how to appeal decisions they didn't like, and usually those went up internally through the program, and probably 98% of them got solved by management somewhere along the line. But very few of them rose above that level. There's now a specific Medi-Cal grievance and appeal process that needs to be used. It's in the special terms and conditions. You need to take a look at that because there's a whole state fair hearing process that's involved, and it's very specific. If people have a grievance and appeal, if they have been denied a service, if they've been given a service less than what they think they should get, if they've been denied payment for a service they think that should have been paid for, they can grieve, and they can grieve to the state. And there are all sorts of rules around that, how that's done, and how many days you have to appeal and to respond to the client and all that sort of thing. So take a look at that information because that's important, and that will be something else that will be reviewed. The next slide gives you some more information on that, but I would really look at what's on the slide before on the DHCS Special Terms and Conditions number 128 to give you the specifics on it. So getting into the last slides, finally, corrective action plans. When the QIC does a corrective action plan, they take a look at how things are being done in terms of meeting the standards, and they're not being well met, and they issue a corrective action plan. They have to be able to say which standard was not met, right? What were the findings of noncompliance, and who will be responsible for implementing the corrective action plan. And until the corrective action plan is implemented, it doesn't go away. You don't meet the terms of it just by responding in writing to a corrective action plan. That's on the substance use disorder side, what people are used to. There's a state review, a DHCS review, you get a corrective action plan, you say, okay, we weren't doing this right, we're going to fix it, we're going to do it this way, differently, and you put that in writing. It pretty much is the end of it. You get a letter back from the state saying, fine, if you do that, everything is fine, and it isn't looked at much beyond that. Corrective action plans will be looked at on reviews to see how they've been done, and until the improvement is actually put in place, whatever you say is going to be put in place is put in place. It's not fixed. Right? Let's see. And then finally, last slide. One more, Yvonne. Good. Closing and quality improvement programs, primary functions of assist DMC-ODS administration. Meet its obligation beneficiaries for access and quality. And, you know, there's an author's note at the bottom here that I just want to read to you because, again, it sort of states what we talked about in the beginning in terms of people understanding that it's going to take a while to implement all of this. And the note says, this is a major task in a DMC-ODS that has never before had a quality improvement program with the degree of structure and oversight that is now required. This is new stuff, it's detailed. It's not too much to do. We'll all get there, but it may take a while to do it, and it says take it one step at a time. All right? Thank you very much.
Well, thank you very much. We're at the end of our time, and I'd like to thank Rod for his participation today and thank all of you for joining us in the audience who are attending. Once again, we encourage you to take a few moments to share your feedback as you exit the session. And with this, we conclude the broadcast. Thanks again for joining us.